Good morning, ladies and gentlemen. So today is my part two of the talk I delivered last week, and this talk was the clinicopathological correlation. All those who watched my previous talk would have gathered that what I meant in that talk, that is, I was trying to make a point that you may find similar clinical appearances, but the histopathology is different. There are slight differences in the clinical appearance, but once you do the biopsy, you expect some different histopathological appearances. So, a knowledge of expected histopathological appearances is important for you to order for the biopsy and what you expect out of the biopsy report. So this is the purpose of these talks, and you can follow me on my Instagram page. And then the learning objectives are once again how the various clinical features correlate with the histopathological appearances, and when the biopsy is indicated, and what do you expect from the histopathology report. So again, repeating the normal histopathology, but because you know all the abnormalities, they have this basis. So just understand that epidermis has 5 layers, usually 4 in all the skin areas except palm and soles, and only in lamina lucida is present in palm and soles, while in rest of the skin it is stratum corneum, stratum granulosum, spinosum, and basal. And the dermis has 2 layers. The first one is the papillodermis, the other one is the reticular dermis. Papillodermis is the layer of dermis close to the retiridges. It is a dense collagen, and then the reticular dermis has a slight loose collagen, but all the adnexal structures lie in the reticular dermis. So the first term I'm going to highlight is the vesiculopustular lesions with crusts and erosions. So just concentrate on these terminologies. That is, the patient has the vesicular and pustular lesions. Since the lesions are vesicular and the lesions are pustular, they will definitely burst open and release the pus or the fluid content, and will lead to crusting. And once the crust is removed, then it will lead to erosions. So vesiculation, pustulation, crusting, and erosion is the evaluation, is how the lesions evolve. So this is a lesion. You can see that there are many small or variable size vesicles diffusely spread over the limb. So this could be anything. It could be a blistering condition, but since the blisters or the vesicles are of different sizes with surrounding erythema, it could be vesicular eczema as well. So if we take here, this is again multiple small vesicles spread over the hand, and a few areas of crusting and erosions are also seen. And this typically is the vesicular eczema or pemphigus we see on the hands. So the expected histopathology of vesicular eczema is extreme degree of spongiosis that leads to intraepithelial vesicles, intraepidermal or intraepidermal vesicles. You can see these large vesicles containing serous fluid and lymphocytes, and the surrounding epidermis show spongiosis. Another picture showing a few small, well demarcated vesicles within the stratum spinosum. So the spongiosis is highlighted in this magnification, and you can see these desmosomal junctions are visible. And when the desmosomal junctions appear visible between the keratinocytes, it means that the keratinocytes are moving apart from each other, or there is intraepithelial edema or keratinocyte edema, and the inflammatory cells will have an opportunity to enter the epidermis through these gaps between the keratinocytes. So this phenomena of entering of inflammatory cells within the epidermis is called as the exocytosis. So the exocytosis can be lymphocytic, it can be neutrophilic, it can be eosinophilic. Now here, you can see these vesicles again, but now the vesicles are almost of the same size and they are grouped together rather than diffusely spread as we saw in the previous picture. So the grouped vesicles with slight erythema is typical of herpes. So this is herpes simplex. And what we expect in herpes simplex, we see intraepidermal vesicle or a blister containing acantholytic cells. These are the acantholytic cells, as well as the epithelial or giant cells. These giant cells are the conglomerate of different keratinocytes, and they are comprising of the keratinocyte nuclei. So this is an epithelial giant cell. It's not a macrophage giant cell. Usually the dermis is unaffected, and there is not much of an inflammatory infiltrate here. Here you can see that there are a few small vesicles and blisters. Lots of crusting is seen, and a few erosions. And this is usually having an acute onset, and it is the bullous impetigo. So bullous impetigo is an staphylococcal infection, and you would see a vesicle or an epidermal erosion with bacterial colonization, and sometimes acantholysis is also seen. So the second term, a closely related term, will be that of bullous lesions. Now we expect the conditions in which large blisters are seen. So these blisters which appear on the skin can be flaccid and can be tense. So by flaccid, we means that blisters are soft, and by the pressure of the fluid which is present in the blister, they would sag like we see here in the picture. So usually the flaccid blisters are those blisters in which the covering of the blister is 1 or 2 cell thick. That is, the blisters are either subcorneal or they are intraepidermal. So this condition in which you can see the pus hanging down is can be if we take a biopsy and we find dense neutrophilic abscess or infiltrate in subcorneal region, and the epidermis underlying is absolutely normal, then we would label it as subcorneal pustular dermatosis. So here you can see annular lesions, and these annular lesions comprises of small vesicles, and while taking the biopsy of these vesicles, we again find subcorneal pustules comprising of neutrophils along with acantholytic cells. So this picture is very similar to subcorneal pustular dermatosis, but since there are acantholytic cells, we would label it as IgA pemphigus. Another condition, you can see lots of vesicles, lots of crusting, lots of erosions. The vesicles are usually not that tense. They are flaccid. The fluid or pus is hanging down, and this appearance, and there are no oral mucosal involvement. So, there are oral mucosal involvement as well. So this is typically a pemphigus vulgaris. On biopsy, you would find a suprabasal blister, and there is acantholysis. Epidermis is distorted. Lots of acantholytic cells are seen within the blister cavity. The basal layer is although attached to the hemidesmosomes, but there are gaps in between the keratinocytes, basal keratinocytes, and this appearance is called as tombstones. The inflammatory cell is not typical of pemphigus group of diseases. There can be inflammatory infiltrate comprising of lymphocytes, neutrophils, or eosinophils, or it can be inflammatory cell deficient. So here is a comparison between the pemphigus foliaceus and pemphigus vulgaris. In pemphigus foliaceus, like in IgA pemphigus, there is a subcorneal vesicle or blister comprising of acantholytic cells and variable degree of inflammatory infiltrate, while in pemphigus vulgaris, the blister is suprabasal with the rim of basal keratinocytes attached to the dermal papillae at the hemidesmosomes. These are the blisters which you would call as the tense blisters. You can see that these blisters, they are well formed and the fluid appear tense. And if you touch it, you will feel the tension. And usually these tense blisters are seen in all the conditions in which the blistering is subepidermal. So whole of the epidermis is forming the roof of the blister, and that is the reason the blister is tense. There are a few erosions as well, which are, of course, the burst blisters. And here you can see a large subepidermal blister. The epidermis is stretched out in the roof of the blister, and the blister cavity contains numerous eosinophils. So if we find eosinophils within the blister cavity, the differential diagnosis is, the first differential diagnosis is bullous pemphigoid, or herpes gestationis, which is the bullous pemphigoid occurring in pregnancy. This condition is also seen in inflammatory type of EBA. So again, we see tense blister in this picture, but here you can appreciate that blistering is in annular fashion, like we saw the superficial vesicles in IgA pemphigus. So this is linear IgA disease. Here, the blistering is subepidermal, but the inflammatory infiltrate is mainly neutrophils and not eosinophils. So this is IgA pemphigus. You can see this in children, and that is called a CBDC, but the histopathological appearance is similar to IgA pemphigus, IgA, linear IgA disease. So this is the linear IgA disease. Now, here you can see some vesicles, some erosion, some crusting, lots of excoriation, mainly restricted to elbows, extensor surfaces of elbows, and also seen on the knees as well as on the back. So this is a typical site of dermatitis herpetiformis, and if we take a biopsy from one of the intact vesicle, we would see the papillary tip microabscesses. So these are small abscesses located at the tip of the dermal papillae, and these are not in form of large blisters. If we see large blisters with neutrophils, your first diagnosis, histopathological, would be linear IgA disease. But if it is in the form of small papillary tip abscesses, then the diagnosis is dermatitis herpetiformis. Now, this is a unique picture. You can see lots and lots of scarring, and there are tense blisters, even oral mucosa is involved, and all the areas which are shown are those which are prone to trauma or friction, and this is epidermolysis bullosa acquisita, EBA. So EBA is typically characterized by a subepidermal blisters without any inflammatory infiltrate. So this is a non-inflammatory kind of EBA, but as I mentioned before, EBA can be inflammatory and can be associated with subepidermal blisters with neutrophils, with eosinophils. Another differential diagnosis of subepidermal blister with neutrophils is Bullous SLE. So the first and foremost is linear IgA disease, second would be inflammatory EBA, and third would be Bullous SLE. This is a kind of blister which is iatrogenic. The blister is induced by cryotherapy, and all the iatrogenic blisters will be clean blisters, subepidermal, like we see in EBA. So no significant inflammatory infiltrate unless the blister is infected. So rather than seeing the vesicles, we see the targetoid lesions. Sometimes these targetoid lesions are associated with vesicles and blisters as well. So this is typical of erythema multiforme. In this picture, the blistering is more evident, but the targetoid nature of the lesion is still obvious. So this is bullous EM. Erythema multiforme is characterized by an interface change. So by interface change, we mean that there is disruption of the basement membrane, there is basal cell liquefactive degeneration, there will be pigmentary incontinence, as you can see. There are colloid bodies, which are the necrotic keratinocytes. So these interface changes are, and in addition to that, the keratinocytes are also seen, the necrotic keratinocytes are also seen within the epidermis, which is called a single cell necrosis. So there is no lymphohistiocytic band-like infiltrate, which we see in lichen planus. So that is not a feature. It is just the interface change. Now, the third clinical term I'm going to introduce here is the scaly erosions. That means we are not expecting large blisters, but we are expecting eroded lesions with some degree of scales and maybe crusts. So what are the eroded lesions? So here you can see on the flexural areas, lots of erythema, then there is scaling and some degree of erosion. So this is an extreme form of seborrheic dermatitis. Seborrheic dermatitis is the only form of eczema in which the spongiosis is associated with neutrophilic exocytosis. So the neutrophils are present subcorneal as well as they are present in the epidermis. And rest of the features are similar to any other eczema. This is a featured condition which mimics the severe or infective form of seborrheic dermatitis, mainly restricted to scalp, trunk, chest. All these areas are areas of pemphigus foliaceus and seborrheic dermatitis. So if you have any doubt that if the patient is suffering from pemphigus foliaceus, you must take a biopsy, and the biopsy would reveal a subcorneal blister without any significant inflammatory infiltrate, while the floor of the blister comprises of 2, 3, or 4 cell thick epidermis. Another condition in which you expect scaly erosions in the flexural area is Hailey-Hailey disease. And Hailey-Hailey disease, whenever you take a biopsy, you would find a partial acantholysis in large portion of the biopsy specimen. So you can see from one edge to the other, lots of spaces or splits within the epidermis. You can see there is no well-formed vesicle or blister here, but the keratinocytes are breaking away from each other, and you can see few acantholytic cells. So this is a dilapidated brick wall appearance or partial acantholysis. So the fourth term I'm introducing today is the papulonecrotic lesions. So in this, you would be thinking of all the diseases in which we find papules, and with these papules get necrosed. So there are a few bit of conditions which are associated with this appearance with some different clinical histopathological appearance. So this is the most common condition in which we don't expect papules, but we expect vesicles which become necrosed and crust. So this is chickenpox. The very fearful condition which we are expecting nowadays is the monkeypox. The monkeypox, like smallpox, is associated with papules, vesicles, necrosis, crust, and scarring. So the chicken pox is not that aggressive. We don't see much of scarring unless these vesicles are removed or scratched prematurely. And another difference from monkeypox and chicken and smallpox is that they affect the peripheral areas like hand and face and feet, while chickenpox is mainly involving the trunk. So if we take a biopsy from any of such vesicle, you would find a small vesicle within the epidermis, acantholytic cells, and a giant cell comprising of keratinocytes. Another condition which is typically associated with papulonecrotic lesion is called as the pleva or pityriasis lichenoides et velluliformis acuta. This is a continuum of a spectrum from a very benign sort of condition, that is PLC, pityriasis lichenoides chronicus, to the severe form, which is Mucha-Huberman disease, or pleva, which is associated with fever and systemic symptoms. So usually the pleva does not have lots of systemic symptoms, but clinically it would look like it would give appearance of several papules, crusting, necrosis. In addition, a few of PLC lesions would also be appreciated. The histopathological appearance of PLC is lens-shaped or focal parakeratosis and interface change. So in pleva, you would see an interface change along with RBC extraposition and epidermal necrosis, which is not obvious in this clinical picture, in this histopathological appearance. Then papulonecrotic lesions are also seen in a form of tuberculite, which is papulonecrotic tuberculosis. So in this condition, there will be lots of papules with necrosis. And if we do a biopsy, you would expect granulomatous inflammation within the dermis. Granulomatous inflammation within the dermis. Caseation would may or may not be seen. There will be giant cells as well, which you can see the Langerhans type giant cell here. Then this appearance is also, although rare, but very typical and very similar to pleva or papulonecrotic tuberculite. It is the lymphomatoid papullosis. Lymphomatoid papullosis is a sort of benign T cell tumor, which is characterized by papulonecrotic lesion. The clinical appearance is not very aggressive, but the histopathological appearance is quite aggressive. And on the basis of histopathology, it is really very difficult to differentiate whether it's a benign condition or a malignant T cell lymphoma. So it is characterized by diffuse infiltrate, mainly by atypical lymphocytes, but other cells are also seen. So lots of atypia is seen. So it is always said that this is histopathologically malignant, but clinically it's a benign condition. So here you can see in this appearance that there are many papules, and in the center there is a necrotic crust. So this is a typical clinical picture of reactive perforating collagenoses. And if we do a biopsy, you would see transepidermal elimination of collagen. So there is a necrotic crust in the center of this papule, And on higher magnification, you can see the collagen bundles which are oriented vertically, showing that these collagen is being extruded out of these erosions. So this is reactive perforating collagenoses, a kind of perforating disorder. The fifth term I'm going to discuss are all the acute conditions, skin conditions, which are associated with epidermal necrosis. So the first and foremost and the most commonest condition which we come across, not frequently, fortunately, but unfrequently, is toxic epidermal necrolysis. This is usually a drug reaction in which suddenly you develop epidermal necrosis, and soon after, this epidermis peels off, leaving raw eroded areas. If we take a biopsy at this stage, you would see lots of epidermal necrosis, no keratinocyte boundaries or cellular definition is visible in this histopathological appearance. And this is another picture. You could see a large subepidermal blister, but the whole of the epidermis in the roof of the blister is also necrosed. Not much inflammatory infiltrate is seen here. This is, again, a picture that is characterized by acute epidermal necrosis, and it is seen as a part of certain malignancies, and it is known as the pemphigus paraneoplasticus. So pemphigus paraneoplasticus has the clinical appearance of both pemphigus and toxic epidermal necrolysis. You would see lots of erosions, crust, flaccid blisters, and pustules, oral involvements. And here the picture is much like pemphigus vulgaris with immunofluorescence showing a fish net pattern. And then, in addition, there will be a linear deposition of IgG or IgM as well with epidermal necrosis, appearance very similar to toxic epidermal necrolysis. This is another acute condition characterized by epidermal necrosis, but this necrosis is in a form of ring or annular fashion. This is hyperglycognoma syndrome or erythema, necrolytic erythema, and this hyperglycogonoma syndrome is characterized by epidermal necrosis and light color keratinocytes, which are the start of epidermal necrosis. So this erythema is called as necrolytic migratory erythema. Sorry about that. Necrolytic migratory erythema. The condition which we commonly see in children is acrodermatitis enteropathica, characterized by annular, scaly, eczematous, necrotic, crusted erosions, perioral, perianal, and on the scalp, and also involving flexures and palm and soles. And histopathology would show parakeratosis, would show epidermal necrosis, pallor of keratinocytes and necrosed keratinocytes, thoracic hyperplasia, and sometimes exaggerated, extravasated RBCs. The term next is the conditions which are associated with erythematous nodules and plaques on the face. A very typical malar rash, you could see a mild degree of erythema and some sort of nodulations in a female. This malar rash is typical of SLE, and if you take a biopsy, you would find an interface dermatosis just like EM, which we discussed a little while ago, and you could see there is no basal layer here because all the cells in the epidermis are spinous layer cells or polygonal cells. So there are no columnar cells. So basal layer is completely gone. And in addition, there are basal cell, there's vacuolations, and then there is pigmentary incontinence and some degree of epidermal necrosis as well. Again, you can see there are erythematous nodules and plaques, mainly in the malar area, but other areas of the face is also involved. So this is again a form of LE, but this is tumid LE. Tumid LE is characterized by the similar changes in the overlying epidermis as we have seen in SLE. But in addition to that, there are lots of perivascular lymphohistiocytic infiltrate with lots of mucin, which is present within the dermis. And the mucin is separating the collagen bundles from each other. We have to order Elsham blue to highlight this mucin. A condition which is very similar in appearance to tumid LE is seen in young female, mainly in spring weather. It's Jessner's lymphocytic infiltrate. So the Jessner's lymphocytic infiltrate is also closely similar to another condition which is characterized by infiltrated papules, nodules, and plaques on the sun-exposed areas, and it is called as polymorphic light eruption. So both Jessner's lymphocytic infiltrate and polymorphic light eruption would have a similar histopathological appearance, and that is of dense perivascular lymphohistiocytic infiltrate in both upper and lower dermal blood vessels. There will be no interface change here in these conditions. This is a picture of rosacea seen in a white, middle-aged male with lots of erythema in the muzzle area of the face, that is nose and surrounding, with nodules, with erythema, with telangiectasias and pustules as well. So a normal rosacea would give this appearance, that is dilated blood vessels, which are hallmark of telangiectasias and surrounding lymphohistiocytic infiltrate. But if we reach the nodular or granulomatous stage, you would see the small granuloma surrounding the hair follicles. So granulomatous rosacea is one of the histopathological differential diagnoses of perifollicular granuloma. The other one is lichen sclerosorum and Mojoki granule. This is again infiltrated plaque seen on the forehead, and we have taken the biopsy, and the biopsy reveals lots of neutrophils within the dermis, upper and lower dermis, with lots of dermal edema. There is not much involvement of epidermis, which may be involved, and this is appearance is typical of Sweet syndrome. So Sweet syndrome can also present as infiltrated plaque or nodule. So the last condition I'm going to discuss is all those conditions in which the infiltrated plaques are associated with scarring. So before we discussed lots of infiltrated plaques, but these are not associated with scarring. But now the conditions which I'm going to discuss are those in which the infiltration are associated with scarring, and most of these conditions are the infections. You can see a solitary infiltrated plaque on the face of a young female, which have healed with very disfiguring scarring. And this is typically seen in Indo-Pak subcontinent, and it is lupus vulgaris. And on biopsy, we find tuberculoid granulomas. The typical features of these granulomas are lots of granulomas which are intermingling, or which are mixed and intermingling with each other. There is lots of inflammatory infiltrate as well. There would be caseation necrosis as well. The giant cells are mainly the horseshoe-shaped giant cells. Lots of caseation and C granuloma surrounding this caseation. this picture is also similar to the lupus vulgaris. We have seen lots of inflammatory, lots of crusting, erosions, and infiltrated nodule. But this appearance is typically seen in endemic areas where sandfly is endemic and the disease is cutaneous leishmaniasis. So the cutaneous leishmaniasis is again characterized by tuberculoid granulomas, but the caseation would not be that prominent. There will be lots of inflammatory infiltrate comprising of lymphocytes, eosinophils, plasma cells, and lots of antibodies will be seen within the macrophages. These antibodies will be the diagnostic of the condition. Here you can see these small papulonecrotic nodules, and these appearance is that of scrophaloderma. Scrophaloderma these small papules can coalesce to form large plaques and with ulceration and scarring. And this is another appearance. And similarly, these nodules, these papules and nodules are also seen in a similar condition, which is sarcoidosis. So the sarcoidoses are characterized by apple jelly nodules, which are part of these plaques. You have to do diascopy, and histology is different from tuberculoid granulomas in a way that these granulomas, they are quite discrete, and they are not coalescing or intermingling with each other, and the surrounding inflammatory infiltrate is quite less, and the giant cells are typically foreign body type giant cells. So here you can see lots of small papules and nodules, mainly on the dorsal surface, and sometime we see these in an annular fashion as well. So these infiltrated papules are granuloma annulare. You can see the necrobiasis. Necrobiasis is distorted collagen, but not totally acellular like caseation. And we see granulomatous inflammation, although the granulomas surrounding these areas of necrobiasis are not well-formed granulomas. They are ill-formed granulomas, but they are mainly in a form of a palisade surrounding the areas of necrobiasis. These are infiltrated plaques, mainly on exposed areas. They are typically fungal, defungal infection, and histopathology should be done. And these patients are mainly belonging to lower socioeconomic strata, mainly are farmers or have some involvement with soil and mud. And you could see the histopathology is that of suppurative granulomas. There is lots of neutrophilic infiltrate with surrounding granulomas. Within the neutrophilic infiltrate, you would see these fungal hyphae. These are the large hyphae, and they are visible even without doing a special stain. So this is pheohyphomycosis. Another kind of defungal infection, which is associated with the large infiltrated plaque or nodule, is chromoblastomycosis. And you can see the copper pennies. These are small. Again, they are visible without special stains. They are seen in the macrophages and as well as outside the macrophages. A typical appearance of a farmer working barefoot in the field is that of mycetoma foot with multiple draining sinuses. If we take, and this is a similar condition in which you could see multiple sinuses involving over the bone or over the lymph nodes. This is actinomycetoma. And both actinomycetoma and the mycetoma foot is characterized by these mycetoma colonies. These are the fungal or bacterial colonies intermingle with collagen bundles, giving a ray-like appearance. And there is dense surrounding neutrophilic and lymphocytic and histocytic infiltrate. You could see here in this picture, there is a large crusted nodule, and there are few other nodules which are not that large and crusted, but in a linear fashion. So this is a sporotrichoid spread, which we see in sporotrichosis, which we see in some atypical mycobacterial infection, like in Mycobacterium cancericea and ulcerans, and it is also seen in some forms of cutaneous leishmaniasis. So if it is sporotrichosis, we take a biopsy and you would find sporotrix. I think I've missed that histology. Here you can see a large infiltrated plaque with a little annular configuration at the edges. So this, if you take a history, it would start as a ring form, as a ringworm. And later on, the ringworm has changed the shape and become infiltrated. So this is typical of Majoki's granuloma. The Majoki granuloma is characterized by the fungi involving the hair follicles with surrounding granulomatous inflammation. PS stain highlight these fungal spores. This is a condition which you see infiltrated papules and nodules, trunk as well as face. This is beyond any doubt Leptomatous leprosy. Leptomatous leprosy would heal with lots of hypopigmentation as well as atrophic scarring. On histology, a case of Leptomatous leprosy, the histopathological appearance is the diffuse sheets of foamy macrophages. There will not be any well-formed granuloma, but the macrophages are in form of sheets. And if you do lepra stain, you would see numerous acid-fast bacilli within these macrophages. Some yellowish tinge is seen in these infiltrated nodules and plaques. These usually heal without scarring, but scarring may be seen. And this is typical of xanthomas. Xanthomas will also have a foamy appearance, but on lepra stain, there will be no Mycobacterium leprae. There will not be any form of granuloma. Some xanthomas are associated with Teuton type of giant cells. So this brings to end of today's talk. So I have left with one more talk on the similar subject. I may take this talk next week or maybe the week next to it. Thank you very much for patient listening and always be commenting on my talks. Thank you very much and waiting for your comments.